Hello and welcome in another video of Medically Us. So in this video I will be briefing about disease which is peptic ulcer disease. So first of all we'll discuss about etiological factors. So type A gastritis and type B gastritis. Type A gastritis can be remembered by 4 A's. It is autoimmune disorder. It has antiparietal antibodies present. It has achlorhydria present and it has anemia which is macrocytic anemia. So due to autoimmunity the gastric mucosa gets destroyed, leading to less acid and deficiency of intrinsic factor, which is further leading to deficiency of vitamin B12, and further due to all this leading to macrocytic anemia. And due to feedback mechanism there is gastrin production hypergastrinemia in type A gastritis. In type B gastritis, it is caused by H. pylori, which is gram-negative cocobacilli. It is microaerophilic. That means it can survive in stomach in less oxygen concentration as well. It is non-spore forming, which means eradication is possible. It is extracellular bacteria producing urease enzyme, and further its spread is feco-oral so most important point about type B gastritis is it has hypergastrinemia and hyperchlorhydria. So what happens is in the gastric mucosa, this urea, it is converted into ammonia by the urease enzyme produced by this H. pylori, providing alkaline media, which leads to irritation of G cells and parietal cells of the gastric mucosa, which further leads to excessive production of gastrin and acid, and therefore eventually leading to ulcers. So gastric ulcer is less common than duodenal ulcer, because in duodenum there is no protection from this extra acid. In worker part of type B gastritis there is screening test which is breath urea test. It is non-invasive and it is investigation of choice. Further urease test, which is invasive test, can be done. Commercial name is Clo test, and biopsy can be done, which is Warthin starry stain to identify H. pylori. It is used to done earlier. So bacteria is black seen by the stain. Further in treatment part, triple therapy is given for type B gastritis. It includes pantoprazole, clarithromycin and amoxicillin. Clavulanic acid can be given in place of amoxicillin in resistant cases. And further quadruple therapy is also there, in which we provide bismuth, which is a surface protective agent. It decreases acid mucosa contact time by making layer over ulcers, so erosion or damage decreases. So bismuth, tetracycline, metronidazole and pantoprazole includes in the quadruple therapy. And in the difference between gastric and duodenal ulcers, so gastric ulcer, it is most commonly associated with blood group A. I have not mentioned it. So gastric ulcer is most commonly associated with blood group A. Its most common site is lesser curvature near incisura angularis, and epigastric pain is present immediately after food intake. So patient will restrict eating food because of this pain. So weight loss is present in this condition, and it is pre-malignant. And in duodenal ulcer, the site is duodenal cap, and the most common blood group associated with this is blood group O. And the epigastric pain in duodenal ulcer is also known as hunger pain. So snacking is done by the patient, which is leading to weight gain. So furthermore, the investigation of choice for peptic ulcer disease is upper GI endoscopy and biopsy. So upper GI endoscopy is done and biopsy is done in gastric ulcer to rule out malignancy because it is pre-malignant. And treatment of peptic ulcer disease is we give proton pump inhibitors for 6 weeks, and if there is refractory peptic ulcer disease, then there is Zollinger-Ellison syndrome can be present. And in complication of gastric ulcer, we have bleeding, perforation, penetration, malignancy, hourglass stomach and gastric outlet obstruction. Bleeding can be due to left gastric artery, and in this upper GI endoscopy plus cautery can be done to treat this bleeding. If it fails, then massive transfusion protocol is followed, and if it still fails, then exploratory laparotomy ligation of the bleeder is done. Due to perforation there is lesser sec involvement, because due to perforation of this gastric ulcer through a opening which is known as foramen of Winslow, the fluid goes to back of the stomach. So there is free fluid in ultrasound seen under abdomen, and gas under diaphragm feature can also be present. Due to penetration, due to this ulcer goes posteriorly slowly, leading to pancreatic cyst and necrotizing pancreatitis. And furthermore, malignancy can be seen because it is pre-malignant, and due to healed ulcer, fibrosis of ulcer occurs, which is leading to gastric outlet obstruction, which is also known as teapot stomach. I know that the explanation part is something which I have not written, so this is why to listen to me is very, very, very important for all of you. It is not just you can take a screenshot of the slides which I am providing, so you have to listen to all the explanations which I am telling you, because I explain a lot. Furthermore, so now we have completed the complications of gastric ulcers, and now in another slide we'll be seeing the duodenal ulcer complications. So we can see perforation, which is more due to anterior duodenal ulcer than posterior duodenal ulcer. So what happens is, if there is perforation in duodenal ulcer, so there can be gas under diaphragm manifestations can be seen, which is also known as the scupola sign and Mouche's sign. And there can be gastric sac peritonitis due to this perforation, and there can also be bleeding seen, which is mostly due to posterior duodenal ulcers, and the source of bleeding is gastroduodenal artery, which is managed by adrenaline given at the base of the ulcer, and further by cautery ligation and exploratory laparotomy. So this is the basic clinical feature workup and the complication part of the peptic ulcer disease. So further briefing the important points, we have to know the etiological parts, which is type B gastritis and type A gastritis. Type B is due to Helicobacter pylori. Then we have to know the difference between gastric and duodenal ulcer, and then complication parts. So in further slide I'll be showing you the classification of peptic ulcer. So there can be gastric, duodenal and esophageal ulcers, and this is modified Johnson classification of peptic ulcer diseases. And further, this is the diagrammatic representation of type 1, type 2, type 3, type 4 and type 5 gastric ulcers. And you have to pause the video to see those slides which I have shown you. So thank you so much. I have not explained those 3 slides at the last. You can pause it and can see. Thank you so much.